Good morning. We're going to go ahead and get started because we have so much information. We'd hate for you to miss something. So I want to welcome you to San Diego. I'm actually a California girl. I have relocated many, many years ago to Colorado, and my name is Pam McClain. I'm a periodontist and have joined my dad's practice back in the late 80s. And had the wonderful opportunity to work with him for over 20 years. And then my niece, Dr. Rachel Schallhorn, joined the practice. So we are really happy to give you a practitioner's view of our implant practice and why we would even consider using something that adds a few moments, a little expense, into our otherwise very busy, hectic schedule. And I think that hopefully by the end of our brief session here, you'll get an idea of how this tool can enhance your practice as well, especially in today's market. Did you want to say anything else, Rachel, about our practice or anything? Okay. Great. So without further ado, we have some fun things going on as well. We're going to do a little interactive piece at the end of the session, so don't leave before that ends. And as I mentioned, I practiced with my dad, and his name is Bob Schallhorn. He was one of the first periodontists to train with Brandmark in the early to mid 80s. And back in 1985, implant practice was very, very different than it is today. We had very strong protocols about how to place implants, where they were placed, and everything was two-stage. In fact, I had been practicing implants for a number of years when I saw a case from Ole Jensen. He's a neurosurgeon in our community, very good friends with him, and this implant was exposed. And I found out that he did that intentionally. What? You don't bury the implant? So things have changed dramatically. Now we rarely bury implants, but certainly we do. And I think one of the big changes that I've seen even more recently is the demand by our patients, by the restoring dentists, to reduce the treatment plan. Patients don't want to walk around with this smile, even if they have some type of temporary removable appliance. They really want to be restored quickly. And we are now seeing a higher risk with our patients. Years ago, we wouldn't consider placing implants in a patient that smoked a pack a day. And I wouldn't say that's common practice, but we're not turning away patients like we did a number of years ago. In addition, patients are living longer. They don't want to have removable appliances. And guess what? They have more health complications. Individuals with diabetes, osteoporosis, altered immune function. You can look at the compromised bone. Again, would we have considered placing an implant up in an air sac, the sinus, 25 years ago? Probably not. Today it's fairly common practice to place implants after we've done a sinus lift. And these areas really change how we do surgery. So today, we really hope to identify some of those risks and give an idea of how this device can help us be more objective in our treatment approach.
And so just as an example of one of those high-risk patients, this is a patient, her name is Osstell, and she's been a patient in our practice for about 35 to 40 years, and she's been treated and maintained for generalized chronic periodontitis, fairly severe, and over time she has lost teeth, and kind of the straw that broke the camel's back is when she lost her kind of last posterior support in the mandibular left posterior. And she's an 80-year-old female, so we certainly had concerns with bone quality. But the biggest issue that I would point out is she has a 60-pack year smoking history. She's been smoking about a pack a day since she was about 20 years old. So certainly this type of patient is someone we'd consider high risk, but we don't want to tell the patient, well, no, you can't have implants. You're going to be stuck with a removable prosthesis for the rest of your life. So how are we going to take this patient and give her something predictably that's going to last and take her from edentulous to a fixed restoration that's functional, healthy, and that she's going to be happy with? And we're going to visit this patient in more detail a little bit later on.
So if you look at this this diagram on the left, again, going back many years ago when we placed implants, we were looking at high quality bone, very dense bone, and we left them in for a long time. So this is the bone quality here, the time is on this end. So now that we're considering early loading or immediate loading, and this is becoming much more standard, we have to look at the risk and the quality of bone. And we know that the higher risk is going to be associated with immediate or early loading of patients that have questionable quality bone. Well, the group from Loma Linda published a number of years ago about those individuals that had immediate load. These are all full arch cases, so either maxillary or mandibular full arch fixed case that had immediate loads. The implants were placed and the appliance was placed immediately at that time. And they wanted to find out the failure rate and what kind of groups tend to show a higher failure rate. Well, those individuals that had an iliac block graft along with guided bone regeneration and sinus graft had a 50% rate of failure, pretty high. But if you just look at a more conservative approach, just those that had a sinus lift previously, this is not immediate, so previous sinus lift, and now they've put the fixtures in, they've splinted them together, 12.5% failure. Bruxism, those individuals, and we have them in our practice, and it seems to be more and more those parafunctional habits that aren't often identified before treatment, they need to be, because look at this, almost 30% failed with bruxism. Diabetes, now in this article I couldn't really find if there was a certain level of control with that diabetes and what level what that may impact, but again, these patients are at higher risk because 28, almost 29% showed failure. Immediate load, immediate extraction, immediate load. So these were, again, not single case, single tooth like this, but it was again, immediate complex maxillary mandibular arch. But when they took the tooth out and placed the implant and immediately loaded it, we had a 22.5% failure rate. And finally, the last point that they summarized was that in this group, the surgeons that had less than 5 years experience had a 5 times greater failure rate. And that makes sense because certainly the longer we do something, the more comfortable we are with it, and we can identify those risk factors, hopefully, beforehand. I'm going to talk about this. So as we look at early load and how that is a risk, let me just introduce you to a patient of mine. This is a 65-year-old female. She had fractured tooth number 11. She's basically got a full mouth reconstruction. She's got high aesthetic demands. This is somebody who is very prominent in the community. She's out doing a lot of events. So her appearance and her ability to speak normally are very important. She certainly didn't want to compromise her other prosthetics to have a bridge, and an implant was what she desired. So we removed the tooth, and this is, a complicated extraction. As you can see, long root proximity. We augmented the area and waited 5 months and placed an implant. Now, this was prior to us having access to the Osstell device, and it looked pretty good. Now, she was really pushing the envelope, and I was trained kind of in the traditional Brandemark way where, gosh, you bury an implant, but now we were already moving to this 2-stage or 1-stage procedures, so I was certainly comfortable doing 1 stage, but she started pushing me a little bit more, and she was ready to get rid of that darn flipper, and she wanted to have a provisional. So I kind of reluctantly agreed to go ahead and let the prosthodontist provisionalize her, and she did that. He did that at 6 weeks. Unfortunately, 6 weeks later, when he went to take the final impression and he unscrewed the abutment, guess what came with it? The implant. So while radiographically it looked fine, clinically, obviously, there was not integration. We waited 4 months, placed another implant. Little snake bitten now. I'm going to bury that fixture and wait. So this is 4 months after we removed the implant. Stage 2 is done at 5 months, and finally a provisional 6 months. So now we're a year and a half from when I took the tooth out. So have we saved any time by early loading? Certainly not. And here's the initial appearance prior to extraction. This is 4 years later. The final crown didn't really get seated until 2 years after I took the tooth out. And sadly enough, the day after that the final crown was placed, she fractured tooth number 6 and had to go through this process all over again. But we learned a valuable lesson. And look real closely, what's happened? Because of these multiple surgeries, we've lost some tissue height. I tried to convince her of doing a connective tissue graft, but as you can see, her smile didn't really show that. That was not critical or important for her. So, the sad thing is that had we had some type of more objective way to assess this implant, we may not have had to wait 2 years to get a final restoration.
And so, looking at that patient, how could we have better evaluated her wound healing, the implant stability, rather than looking at radiographs? And certainly radiographs are important, but how can we really assess how each individual patient is going to heal, particularly in those high-risk cases? With the patient that Pam just showed, that's a canine site. Depending upon her occlusion, any parafunctional habits she may have, her risk, and especially for immediate load on a canine site, the risk is fairly high. So assessing that wound healing and then assessing that implant stability is very key in seeing, when can we load these implants, what's our risk. So really, implant stability develops out of bone healing. So really, we look at the principles of bone healing and how they influence implant stability over time. So we know just through wound healing studies that we have an initial stage when we injure the bone. The initial stage is an osteoclastic bone resorption. So the body's going to initially resorb a little of the bone, and then a secondary stage of osteoblastic bone deposition is going to come in. And this is a slide I actually borrowed from my colleagues at San Antonio in a wound healing study that they performed. And it just shows some different...
Top one.
It shows... sorry about that. It just shows different phases of bone healing around an implant. So this is 2 threads on an implant, and then this is very soon after the implant was placed. You can see the native bone here, and then some initial bone healing between the threads of the implant. And as time goes on, you can see an increase in that bone deposition between the threads of the implant, and that bone healing is what we know as osseointegration. And so when we look at our types of stability, we've got primary stability, which comes from the mechanical interlocking of the threads into the bone. And that's what we get initially. And mechanical stability is very important for implant success. And then moving on, as that wound healing progresses, we develop our secondary stability. And that really is a biological type of stability, and that's achieved through bone healing or wound healing. And if you look at the graph on the right side, you get this green line here, which is our total stability. And that's really what we're interested in and what we're assessing through the wound healing. But what's going on underneath is our initial mechanical stability decreases in importance, not that the threads are going to change at all, but what comes into play as wound healing progresses is that biological stability. And that's what we're really relying on and wanting to track long term, that once we have that secondary stability, that implant's ready to take some load. So looking at the measurements of stability that we currently have, we've got a few different things that have been used throughout the years and are still used today. One important measure is insertion torque, and this is something that we certainly pay attention to in our implant practice. What type of torque value are you getting as you're placing that implant? That really gives you a key or a window into that primary stability. And then torque and abutment placement as well. And what about reverse torque? We put some question marks there just because it's not something that we routinely do in our practice, but there are many individuals probably out there that do reverse torque tests, and it is something that was probably used a lot more in the past, but it is a measure that is used. And then percussion test. If you harken back to the days of the perio test, which was a test designed for natural teeth, on implants it may not be as translatable, but tapping on that fixture, and anyone who places implants, I tap on my fixtures sometimes, and if you get that nice ting, that metal sound, it makes you feel pretty good, as opposed to the dull thud, which is absolutely a concern. But what is that really telling us that? And is that a quantifiable measure? I'd say no. And then resonance frequency analysis. And this is something that we can quantify and track over time. So that's what we're here to talk about today and really focus the lecture on. But, looking at objective versus subjective measurements of implant stability, really the two that we have that we can objectively track over time or measure is insertion torque and resonance frequency analysis. So I wanted to talk a little bit about insertion torque. This is essentially a measure of primary stability at implant placement. Insertion torque can vary for a number of reasons. The implant characteristics can certainly influence insertion torque. The width of the implant, the length of the implant, the thread pitch, and the thread design. This is not one of our implants, but this is a patient who came in with an existing implant with fairly aggressive threading on that implant. And then this patient on the bottom had implants placed by 2 different surgeons 2 different times. You can really see the difference in the threading, a less aggressive threading on the more posterior implant with more aggressive threads on that anterior implant. And those certainly are going to affect your insertion torque and affect your primary mechanical stability. And then bone density. Bone density varies among patients, and it varies in different areas of the mouth as well. So if you look at this patient, we've got 2 implants in the posterior maxilla, where we know the bone is not as high quality, and this patient had a previous lateral window sinus lift. So I would expect my insertion torque to be a little less there versus the patient who has 2 implants placed in posterior mandible, where we know the bone density to be usually much greater. And then the differential osteotomy and implant size is also important. Any given implant system is going to have certain osteotomy preparation protocols, so that varies among systems, but there are also different protocols based upon if you have a more dense bone or a less dense bone. So all of those can affect insertion torque, and how is that going to translate into our secondary development of secondary stability and biological stability later on. So the other objective measure that we have to assess implant stability is resonance frequency analysis. And we wanted to just go in a little bit what that is, pretty basic. So resonance frequency analysis, essentially when you're utilizing it with the Osstell device with your patients, you've got a couple of components. You have a magnetic probe that is attached to the device itself and a magnetic peg. And the magnetic peg is, we call it a smart peg, and that is inserted into the top of the implant. So it's threaded and you screw it into the top of the implant. And the magnetic probe will emit pulses to the peg. The peg responds and provides a feedback frequency to the probe. And the probe interprets that and derives the ISQ value. So that ISQ value is what we measure and kind of track over time. And that's really what we're interested in. So
if you look at what the RFA or resonance frequency analysis is and implant stability quotient, that's the number that we use, the number we derive from the Osstell unit. So RFA is measuring the resistance to lateral movement. And that's basically micromobility. And really what we have in function. It's micromobility, the lateral movement. And if you look at this graph on the right, when they looked at the RFA, the numbers in hertz of the resonance frequency analysis numbers, and they translate them into this ISQ value, it's not linear. Even though the range goes from 1 to 100, it's not that 1 and 100 are in a straight line. What's interesting is that when you go from 60 ISQ to 70 ISQ, the micromobility decreases about 50%. So what does that tell you? Well, gosh, 70 is not just 10 better than 60. It's really quite a bit better. And that number may be important. We know that you get a higher frequency when you have more bone-to-implant contact. So that makes sense. It's just like the insertion torque. So that's important as well. And if you look at torque versus RFA, what does torque measure? Well, it measures resistance to shear forces. So you place an implant in a small osteotomy and you really grind down on it with a high insertion torque. That's what you're measuring. It's resistance to shear forces versus RFA, which measures resistance to lateral movement. Again, it's that ability to limit micromotion, because we know that if you have more motion, increased mobility, increased lateral movement, you're going to have a lower success rate. So in function, the RFA value is much more important than that torque value as we go long term, because this now is going to become biologic and we're going to achieve osseointegration. So some of the earlier studies that evaluated this RFA analysis, they wanted to find out what happens when you subject these to immediate load, implants to immediate load, and what does the ISQ or RFA evaluation do. And we can look at this study by Glauser in 2004 where they took 81 implants and all of them had either immediate or early loading. They were single tooth implants, they were multiple fixed cases, removable cases, so it was all a broad variety of restorative options with these 81 implants. But they were either loaded immediately or within 2 weeks. On average, the initial ISQ was 68, so it's a pretty good number. But what happened is they evaluated these at 1 month, 2 months, 3 months, 6 months, 12 months. At 2 months, the average ISQ dropped, so it went down to 60. And then there was a gradual increase over the next 10 months. They wanted to find out what happened to those ISQ values in the sites that showed failure. So 9 of the 81 implants failed for an 11% failure rate. And what was interesting is that even though all the implants dipped down a little bit, as you can see in this top line, in this diagram, these are the, gosh, I can't read the numbers, but this is the ISQ value. This is time. So within 2 months, you can see there's this dip, and then they gradually increase. So the implants that were successful dipped a little bit and then came back up. The implants that failed continued to show a decrease in their ISQ values. And in fact, when the ISQ values dipped down to somewhere between 49 and 58 after 1 or 2 months, it showed an 18% risk of failure. And if the values dipped even lower, somewhere between 39 and 48, the failure rate was 33%. So this seemed to help predict what happened to those implants long term.
And so, through just research and looking at our patients, we're starting to get an idea for these numbers and what types of numbers we're getting in the implants, but how do we really interpret these values and what do they mean? So when evaluating ISQ, what we see just kind of as a general average is we're seeing these values around 70. So that's kind of where many implants lie, right around 70 as an average and thereabout. And if we place an implant with a high initial ISQ, typically what we're going to see over time as that bone remodeling progresses is a small decrease. So that's within normal limits to see a decrease. But what we're looking for over time is that for that ISQ value to stabilize. So in our practice, we're actually measuring the ISQ at several time points and tracking that for each implant and each patient. So here you can see an implant that was placed with a very high initial ISQ, small decrease with bone remodeling is normal, but we want to see that stabilizing over time. And then if on the flip side, we have a patient, we place an implant and that implant has a lower ISQ, what we expect to see with that development of biological stability, that osseointegration, is to see that value increase over time and then again reach a stable level. So really what we're getting at is the trend is really important. It's not the absolute value. And we have a lot of our patients, they start paying attention to these numbers and they want 100, but nobody ever gets to 100. I think the highest I've seen is about 90, maybe 87. But tracking that over time and seeing, okay, when did we place the implant? What was our stability? And what's it going to be at about 6 weeks and so on and so forth? And really we're looking to see that measurement stabilize because not every implant's going to get to 70, but if we have a value that stabilizes over time, we feel that that implant is stable and ready to bear the load of a restoration. On the flip side, looking at trends, something that is a big concern is to see a progressive decrease over time. And that's something we consider to be a risk behavior for an implant. So kind of understanding what we're focusing on, interpreting those values and how they relate to stability. How do we apply this in our clinic and how do we apply this to our patient coming in on Monday morning? So when we have a patient with a high initial ISQ, typically what we're going to see is a small initial decrease over time and reach stability. But when we have that very high initial ISQ and we consider that to be 70 or above, we consider those implants as potential for immediate or early loading. If over time we see changes that are indicating a negative trend, that's a warning sign for the implant, and we will likely delay loading and keep a close eye on that implant to make sure it doesn't continue to progressively decrease. And then looking at our patients with a low initial ISQ, and in our practice we consider a low initial ISQ to be below 60, we expect to see those values increasing over time as bone healing and the osseointegration progresses. And these are patients that, the implant is stable. We just have a lower measurement. So, we're not having mobility of the implant or spinning of the implant at the time of placement. If we have something that's 55 or less, if you take a look at, it was an article published in, I think, Perio 2000 and 2008, what they recommended is a value of 55 or lower, some sort of action is recommended. So that could be potentially you place an implant, you have very low ISQ, maybe remove that implant and place a larger diameter implant that day to help those threads engage into the bone and improve your primary stability, which is going to facilitate the development of osseointegration later on. Or potentially just do a two-stage protocol, so bury the implant so it can heal without any external forces being placed upon it, or allow a longer healing time. So those are potential actions that we may pursue if we have a low initial ISQ. And something that you've probably noticed is we've got this value in between 60 and 70 that I haven't really addressed. And certainly that's where you really take a look at the ISQ, but also the other factors, patient risk factors, systemic health, maybe the insertion torque when the implant went in, bone density around the implant, and location of where that implant is and how much risk loading is going to present.
So now what we'd like to do is just spend some time talking about how do we use this in our practice. You kind of know a little bit about the science of this. Now let's talk about how to apply it. And I would say for all of our implant cases, and there are rare exceptions to everything, so you can never say it all the time, but every implant that we place, we get a baseline ISQ value. And we take measurements around 4 areas of the tooth. So we start on perhaps the mesial, go to the buccal, wrap around the distal, go to the lingual. And we'll record both the high and low values. And we keep this record. I know that the IDX has it right, tracks it for you. It's very nice. But we also keep that record in our charts. So our patients, we can write it down, we can look at it real quickly and tell them what their values are. Based on that value at the time of implant placement, that's where we decide what type of loading protocol might we consider. If it's too low, if it's less than 50, depending on what else is going on, we might consider removing the implant, or as Rachel said, placing a larger fixture. If it's above 70, we could consider this case for an immediate or early load, as you see here. And also, it helps us identify whether or not this is 1 or 2 stage. This happens to be an immediate extraction implant placement. Our ISQ value was at 70, 73. It's a premolar. We decided to do this just as a 1 stage. Versus an ISQ of less than 60, oftentimes we'll consider or use a low 2-stage procedure, as you see here, and bury that implant until a later time. So how do we apply that? So we've now are looking at single-stage protocol in our practice. Basically, if our ISQ value is above 60 or right around 60, and that can vary, for the most part, those are the cases that we'll consider for a 1-stage, single-stage protocol. But again, we are really ignoring for the moment all those other factors that you have to understand, the risk factors associated with the patient that might help you lean towards a 2-stage or a 1-stage procedure. Based on that, we oftentimes will then reevaluate that at 6 weeks. Now, typically we don't do it sooner than that because there is some evidence to suggest that just taking the healing abutment off and on can alter or cause problems with wound healing and the osseointegration process. So we'll typically check it at 6 weeks, or if we feel that that's a little bit questionable, we might wait 3 months. And I typically tend to wait longer than Rachel does. That's that old school in me trying to change. But then at the 3 or 6 month evaluation, whatever we're doing that at 6 weeks, we'll continue to repeat that process every 4 to 6 weeks until we see stability or our ISQ value is above 70. So here's a case in point. Implant was placed. Our ISQ value was at 59, so it's really borderline. But for this patient, there was no other risk factors. We did it in one stage. So now we're going to want to continue to reevaluate that until we're ready to load it. Again, if that ISQ is over 70, we'll consider immediate. We might consider an early loading or delayed. In this case, because it was 59, I decided just to wait until 3 months, recheck the ISQ. I wasn't thrilled with an ISQ value of 63. I continued to wait 6 months. Now, I promise these are not the same radiograph. I cropped them just so that the angles were the same, but these are x-rays taken at baseline 3 months, 6 months, and 9 months. So it wasn't until 9 months that ISQ value got to a point where I felt much more comfortable and released the patient for restoration. So here's 1 year and 4 years later. So certainly the value to me was that this was not a case that we wanted to jump in. I can't tell from the radiograph any change at all. And yet I know there's some micromobility, and I also know that we've had this 50% reduction in micromobility from that low number to over 70. So let me just show you Hazel. Hazel, when you see the name on the schedule on Monday morning, you just want to call in sick because it's such a difficult case to manage. You know, the tongue is everywhere. She can open about, 3 millimeters. That's it. This is it. We all have those patients, and I don't know. I think we have more in Colorado, but perhaps not. She had this bridge for many years. It kept failing. She wanted an implant. She wouldn't consider orthodontic uprighting. So here we are faced with some problems. We've got concerns with the width of bone, the nerve position, and yet I know I'm going to have to do augmentation, and I really want to do one stage because I don't want to have to subject this patient to another surgical procedure. Even how minor it is, I know it's not going to be an easy one. So we place the implant, and we graft it, and then before we graft it, we take our ISQ value, and lo and behold, we actually have a pretty secure implant. This is a narrow fixture. It's like a 3.3 millimeter fixture. But our ISQ value is 66 and 73. So I felt pretty good. I felt, very happy that this was going to be one stage procedure. So lo and behold, she comes back for me to check that. I waited 3 months, and look at the bone. It looks like we've lost integration of that implant. It looks like there's the remodeling that's occurring is not favorable, and based on wound healing studies, she should have started seeing an improvement, not actually what looks like a loss of bone. And our ISQ value dropped significantly. Now we're at 53, 57. There was no purulence. The patient was asymptomatic, so we decided to just ride this out. I waited another 2 months, took an ISQ value. Now it's trending up. Previously, I may have taken this implant out. When I see that kind of bone loss at 3 months, I'm very concerned. So now we're seeing a trend upwards. So we've got 61, 64. 7 months, we're getting closer, 66 to 70. It's still not to that baseline measurement that we had at the time of implant placement. And it wasn't until we hit 11 months. Now we're starting to see a little bit more remodeling, a little more calcification of the bone. I released the patient because we had an ISQ value of 70 and 75. So that's a big jump from the 53 that we had at 3 months. The patient was restored, and this is 4 years later. And you can see, yes, there's been some crustal bone loss, but 1 or 2 threads, which is typical for many implants. So we saw a very, very predictable outcome by waiting and allowing the trend to show us an upward value. And remember what we said about that ISQ value. This is that patient's ISQ values at 3, 5, 7, and 11 months. That micromobility decreases about 50% when we move from that ISQ value of 60 up to 70. So how do we apply this to a 2-stage procedure? So again, we're taking those ISQ values at baseline at the time of implant placement, and if it's less than 60, that's when we will consider a possible 2-stage. And then we'll recheck that ISQ value at 3, 6, 9 months. It depends upon that initial value and the patient risk factors. So the higher the risk, the longer I'll wait. I'll continue to repeat those until we get that ISQ value at a stable rate, certainly above 60. And here's a case in point. So as I mentioned, I had the wonderful opportunity to join my dad in practice, and then my nieces joined me. So it's been a great time. But what's wonderful about a practice like that is that you have patients that have been there for many, many years. It's also sad because guess what? They get old and they start to die, and it's really, you become attached to these people. Well, this guy had surgery with my father, and this was 20 years before we had to do this. He'd had a distal buccal root amp, and so successful for over 20 years, but that tooth started to fail as well as tooth number 4. So it had to be removed. We took the teeth out, did ridge augmentation, and then waited to do our implants, and at the same time did an osteotome sinus elevation. We took the ISQ values, and lo and behold, our number 3 implant, the one that's up in the sinus, has a 58, but look at the low reading we got, a 25. This was early on when I started using Osstell. The implant went insecure. It wasn't spinning. I didn't use a real high torque either, but it felt secure. So we left it, and certainly our number 4 fixture looks good. So we bury the implants, and now we monitor the healing. And really the only way to monitor it now is radiographically. So here it is at 2 months. And at 5 months, we can start to see that bone remodeling. We plan our second stage at 6 months. And look at the big change in the ISQ. So our initial ISQ value for the number 3 implant was 58.25. And now we've got a nice stable number, 74.81. Boy, I tell patients, anybody that reaches 80, they're rock stars. They're doing well, and they get kind of excited about that. But ISQ value actually has dropped a little bit on number 4. And based on what we have seen with these trends with the bone remodeling, when you have a high ISQ value initially, you'll see a little drop. Am I concerned about that? Not at all. Not at all. So the patient was restored, and this is now, this was a 3-year post-op showing excellent stability. Now, does everybody have their little clickers, their little, So we're gonna let's not put the Slido up yet, but just have we explained how to work this? They have flyers? Okay. Now, if you want to participate, get your flyers out, because I think you have to log in. Slido.com? Okay. Okay. Does everybody who wants to participate in the interactive part have the information they need? If not, raise your hand. Okay. So let's look at case 1. This is a 35-year-old female. She's fractured tooth number 9 at the gingival margin. As you can see, she's got a very high smile line. Her aesthetic concerns are quite high. She's a meeting planner. She travels all over the world and is constantly engaged in conversation and discussions. So she's really already putting a lot of concerns forward, and she knows that this papillae is going to be a big issue. Now, if you look closely, the tooth number 9 already is showing a little bit of recession, and we had a long talk about this, that she's going to probably lose tissue height, and one of the ways that we can help actually ensure a better outcome is if we can extrude that tooth a little bit. She agreed only because they could do a lingual appliance. I'd actually never seen this done before, and because of her overjet, this was feasible. So they extruded the tooth. And here you can see this is now a number of months after the extrusion. And as I mentioned, she had enough of an overjet that she was able to proceed this way. So what are our options? Here's your choices. Number 1, and let me just go back really quick. One of the concerns also is root proximity. So we've got some issues with root proximity, and you don't really know what the buccal lingual bone looks like, but I can tell you she has a thin buccal plate, but it's not dehisced. So option number 1, you can graft after you extract the tooth and defer placing the implant. You can immediately place the implant but do a delayed loading. Or you can vote to place the implant and load it immediately. So now our little time, do we have time for them to vote? We have one person, one voter. Yay, thanks, Will. We're up to 4. We'll give it another few seconds. Oh, this is the time? Oh, good. Look at this. All right. Okay. These are the kind of statistics I like. I had a book when I was in dental school, and it was a little book, and it was called How to Lie with Statistics. Great book. All right. Here's the answer is immediate implant with immediate provisional crown. Okay. And let's see, that was what percentage? 50, 70, 60? Oh, as we talk, they're changing their minds. And we have only 7% would immediately place the implant and delay the loading. We're up to 40-some%. Okay, let's hide the Slido. Okay, we're about half and half. All right, well, let's see what happened. Well, I did place the implant immediately, and we had an ISQ value of 72. So now that you know that, you have 3 more options. You can basically, do a connective tissue graft, bury the implant, do whatever bone grafting you need to do, and in essence, bury the fixture. You can go ahead and place a healing abutment and delay the loading, or you can place the immediate provisional crown. So, Slido, tell us what they're saying. And as we're waiting for this is as I mentioned, high aesthetic demands, big concern for that highly scalped gingival margin and those papillae. So we've got, big issues about aesthetics. Graft and place immediate provisional crown, graft and place healing abutment, graft and bury. So hardly anybody, there's a few that might bury the implant with a connective tissue graft. I'll give you another, let's see. Oh, they're changing their minds. Okay, well, let's hide Slido and see what you're doing. You did exactly what I would do. Now, I will tell you, this was the absolute first case that I did immediate provisionalization on. And there were a couple of reasons why. She had a high ISQ value, implant went insecure, and we had positive tissues around there. This was a deep overjet, so we weren't worried about her parafunctional habits if she had any. And this is the final crown when she came back at 6 months for me to check her, since she lives up in Aspen, which is quite a ways. And that's where she is 11 months post-op. From there to there, I would venture to say most people would not know anything was done. In fact, if anything, she looks a little bit better now with the new crown. Okay, we'll do, we've got a couple more cases, so let me show you this case. This is a patient that we had to extract tooth number 3, and she was already missing the premolars, so augmentation was performed. Implants were placed at 11 months, and at that time an osteotome sinus elevation was performed on the posterior implant. Here's our ISQ values. The tooth with the sinus lift had a 62. Tooth number 4 had a 62, and tooth number 5 had one of those odd readings, a low of 55 and a high of 79. So what are your options in this case? I'm going to give you 3 options. You can bury all the implants and do 2-stage. You could place healing abutments on all the implants and do a 1-stage, or you can just consider burying the number 3 fixture. So Slido, show us what people want to do. And you've got, we'll give it a few minutes. Bury all implants 2-stage is it's interesting. Change your mind? Okay. Yeah. Well, when you have a low value, a low number, our N number is low, one person makes a big difference. You see that one vote counts. I'm just going to tell you, one vote really counts. All right, so the vote, this is a very smart group because, in fact, that's exactly what I did. I thought the risk was too high. In all the cases, it just made more sense to bury them all. Let me pass this back on to you, Rachel.
All right, so we've got 2 more to go through quickly so we can get Will up here. So this is a patient, he lost tooth number 30 due to a vertical root fracture. And we extracted the tooth. Likely he would have been ready for implant placement a little bit earlier than 6 months, but due to other circumstances, he waited about 6 months to have the implant. Excellent bone quality at implant placement. And when we placed that implant, went in with very high insertion torque, and the baseline ISQ was 80. So taking those factors into consideration, the options that I gave were to immediately load the implant consider early loading at about 6 weeks, or perform a delayed loading approach.
Okay.
It varies quite a bit. Just a vote or two. All right. So
give the majority for
yeah,
immediate.
I think most people have voted. And so, what I did in this case is, being a molar site, I didn't want to do an immediate load. Just I felt that there was risk with that. And the patient, it wasn't aesthetically a concern for him, and he wasn't pushing for that. So because we did have such a high primary stability, we were considering doing an early loading at about 6 weeks. So I had him back at 6 weeks, and when I see these patients at 6 weeks, typically I'll check the ISQ. Depending upon what I see, if I think, okay, this is a nice stable ISQ, we'll then get a radiograph. But I typically don't take a radiograph right away if I think I'm going to have him back to check ISQ later on. So when I checked the ISQ, it was 66, 67, and I was definitely concerned to see such a significant downward trend, particularly at the 6 week time point. So we did take a radiograph, and this is what we saw. So taking that into consideration, we've got some options. We could take the implant out, consider more of a delayed loading approach, or just say, you know what, I still think it's okay, and we'll just load this implant. So 3 options there.
Mm-hmm.
All right. Very smart group. So, and some people that maybe would still load that implant early. So, again, what I decided to do was to just pursue a delayed loading. I felt that removing the implant was certainly a drastic measure, and based upon that really high insertion torque, what I think happened was a pressure-induced osteonecrosis when that implant goes in so tight that it compresses the bone laterally, and the blood supply can't get to the surface of the implant to help heal it. So we basically just left him in the healing abutment and allowed this to heal and tracked the stability over time. So at 3 months we checked it and it came back up to 70. I was pretty happy with that. And we allowed it to heal a little while longer just because of what we were seeing on the radiograph. So at 4 months we were at about 74, and then at 6 months we were up to 75. And you can see a trend toward increasing bone density around the implant. And so at that point I felt, okay, we're safe to restore this implant. And this is about a year after we placed the implant. So you can see the bone density has really improved laterally on the implant. We do have a little bit of crustal loss, but this patient has been stable for a number of years now. So I would say the ISQ kind of helped us identify a patient that had we loaded early, potentially we may have lost the implant or developed more serious complications. And again, that patient was asymptomatic. He felt fine, so that's why I felt that leaving the implant and monitoring it was a good decision. And so this is Osstell. This is going to be our last case, and this is the patient that I showed a little earlier. So she's our 80-year-old female, definitely concerns with bone density, very significant pack-year history of smoking, and generalized chronic periodontitis. Tooth number 20 was extracted due to an endodontic infection. So from what I showed earlier that we eventually get some implants in there and get her restored. But how are we going to take her from the edentulous situation into a fixed prosthetic situation predictably and in kind of the safest and healthiest manner possible? So I placed the implants, and number 19 had a very low ISQ reading of 35 and 43. So this is definitely in what we consider our risk range. Number 20 had what I would consider to be a very good stability. So I will tell you that number 19 went in, and it was not mobile, and it was not spinning. I did not test it with a lot of torque, but I didn't have any mobility that I could identify on that implant. So based upon those, what type of options would you pursue? You do just a single stage protocol, a two-stage protocol, or maybe just bury number 19 only, or remove the implant at number 19 and think about placing maybe a wider diameter fixture or something. Okay, good. So again, we have a very wise group here. What I chose to do was to bury the implants. This patient, that number 19 implant is something I might have considered for removal, but I used a 5mm diameter, and with that implant system, I didn't have a wider diameter to step up to replace it with a wider diameter implant. So I actually talked to the patient during the surgery and said, we can take this implant out, graft the site, and come back later, but she understood the risks and said, I want to keep this implant in. And I felt because we didn't have spinning, we didn't have mobility, this was a safe way to proceed. So I buried the implants. You can see our initial ISQs there. I took a radiograph at 3 months, but because of her bone density, smoking risk factor, I just decided to leave these implants sleeping for 6 months before we were going to pursue restoration. I exposed them at 5 months, and the ISQ values had dramatically increased. I was surprised to see number 19 going up to 85, 86, and then number 20 going from 80 to 85. And then finally at 6 months, we cleared her for the restoration, and this is 4 years post-placement. And you can see that mesial cantilever, that's where we extracted the endodontically infected tooth. And the endodontist that I worked with just recommended that we not place an implant in that site. So that's why we placed the type of restoration that we did. But she's been stable. She comes in for maintenance every 3 months and is doing very well with healthy implants and good bone levels.
So in summary, the value of using this tool in our practice has really been that we now have an objective measurement. And it helps us in terms of implant staging, whether we're going to do single stage or a two-stage procedure. It helps in terms of our loading protocol. Can we consider an immediate or early loading, or do we have to defer it based on our ISQ values, since the radiographs don't often give us that information? I'd say equally as important as this objective tool is how we communicate. And first of all, with our patients. Remember this one right here. Nancy clearly understood by the time we were doing tooth number 6, and we now had an objective measurement, she understood the value of being objective. I was no longer the bad guy, because up until that point in time, it's always the periodontist and the surgeon's not releasing the patient for restorative, and we become the bad guy. We don't want to be that. It's now that tool, that instrument is telling us, no, you can't. And it's also been a great tool for us in terms of communicating with our referring or restorative dentists and helping them understand the value of and importance of this stability device. So with that, I want to just thank you for paying attention, and we're really proud of our Denver Broncos. So that's Rachel and her husband up in Steamboat, or up in Vail. Thank you so much.